First of all, it's so heartening to see 250 people in the hall. Hardly within 4 minutes of when the conference time is stipulated to start. I guess this goes to show that when you have star talent like Dr. Grube, Susheel, Ganesh, and Vinny, you don't need to do anything else. You just need to turn the connection on and then watch it burn like this. I don't think there are any of us who are here who don't know the 4 people I'm talking about. But to give a very quick introduction, Dr. Grube was part of the team that invented, with Dr. Labat, the part of the team that invented the co-valve we're all using. Susheel, of course, Director of Structural Heart at Colombo University Hospital, one of the centers that does the maximum research on structural heart and transcatheter therapies. And Vinny, I think each and every one of us who's doing transcatheter work would be handicapped without his app, apart from being a brilliant surgeon and inventor of some of the new tech that we're all going to be using. And Ganesh, I like to call Ganesh the granddaddy of all TAVR proctors. He's proctored all my proctors. He's been in the TAVR field way back when the valve started. With that, I'm going to hand the floor over to Dr. Grube. Dr. Grube, the floor is yours.
Well, thank you very much. Wonderful to be back, even though only virtually, to India, particularly with you and my very, very good friends that you just mentioned. And I'm very happy, very proud to be able to open this session with a topic that's obviously very interesting. And the topic you gave me, should all aortic stenosis patients be considered for TAVI first? I'm going to start with the disclosures as seen on this slide. And I would like to continue with a disclaimer. Suppose all things being equal, less invasive therapies will always reign supreme. And I think this is a fair statement because not even the surgeons, if there are better options, less invasive options, they would go for the lesser way. And the evolution of TAVI from 2000 to present are summarized here. It has been a success story from 2000 when Alain Cribier did the very first to the 2019 when Evolute and Sapien were approved for low-risk trials. The whole thing was a success story all along. We hardly had any setbacks. We went straight through with very robust clinical trials, and the results we would like to summarize here now. So if we look at key patient and physician endpoints, I would like to start that the incredible success of TAVI across the risk spectrum has proven it is the therapy for almost all patients with severe symptomatic aortic stenosis. TAVI has demonstrated it is a good or even better than the previous gold standard than surgical aortic valve replacement. So if we look at the endpoints and the discussion points here, what matters to the patients and to the physicians? The mortality, obviously, to patients and physicians, stroke the same way, quality of life, and I would like to also say that resource utilization has also been the key point for these questions. TAVI has a mortality advantage over surgery. Early TAVI studies demonstrated all-cause mortality rates similar to or better than surgery in patients with high-risk trials, here partner and CoreValve high risk. The clinical trials in intermediate patients demonstrated similar or better mortality than lasted out to 5 years in intermediate risk patients. And finally, clinical trials conducted with low-risk patients showed reduced mortality out to 1 and 2 years compared to surgery, partner 3 2-year mortality, and Evolute low-risk 1-year mortality. If we look at the meta-analysis of 7 randomized controlled trials, these show a 12% relative mortality risk reduction up to 2 years for TAVI compared to surgery across the risk spectrum. And on the left side, you can see high, intermediate, and low-risk trials all noted. TAVI does have a mortality advantage and is the preferred treatment option. TAVI has a stroke advantage over surgery. Stroke is a devastating complication, and patients fear this more than death. Although a concern early in the TAVI experience, stroke rates have decreased with improved operator experience, device technology, and lower delivery profiles as shown here on this slide. Second generation valves showed similar or significantly lower rates of stroke with TAVI compared to surgery at 30 days in clinical trials to the right with TAVR and surgery. A meta-analysis of 7 randomized controlled trials showed a 19% relative stroke risk reduction up to 2 years for TAVI compared to surgery. Stroke rates are better than surgery with contemporary devices in clinical trials, making again TAVI the preferred therapy option. Also, TAVI has a quality of life advantage over surgery. If we look at the adverse events, TAVI provides reduced rates of acute kidney injury, atrial fibrillation, and bleeding as shown on this slide. TAVI has a faster recovery. TAVI patients have significantly faster recovery compared to surgical patients, as shown here. Quality of life and getting patients back to their active lives is especially important in younger, low-risk patients. The recent low-risk trials show significantly faster recovery in TAVI patients versus surgery. This benefit was observed in patients with and without clinical events. Rehospitalization. Rehospitalization occurred significantly more often in surgical patients compared to TAVI at 1 year in low-risk patients, looking at the Evolute low-risk trial on the left and the partner trial on the right. Better hemodynamics. TAVI hemodynamic outcomes are significantly better than surgery, which maximizes physical capacity post-implant, leading to improved quality of life. New York Heart Association functional class. TAVI patients are consistently in New York Class 1 more often than surgery, have faster and lasting recovery and better quality of life. TAVI has also improved resource utilization. If we look at Partner 2A and TAVI, and we look at procedure time, ICU stay, and total hospital stay, TAVI has reduced procedure times, ICU stay, and total hospital stays, allowing hospitals to treat more patients and work more efficiently. TAVI is more cost-effective over time. If we look at the Partner 2A 2-year and SAPIEN 3 1-year, you can compare the two: surgery and XT, less expensive, and surgery S3, less expensive than surgery. So it looks like they're more cost-effective. The principal finding from the Evolute low-risk trial also showed TAVI in low-risk patients is very cost-effective, as shown on this slide. Remaining challenges then: higher pacemaker rates, but they are improving. Pacemaker rates have been consistently higher than surgery. However, rates are decreasing with improved operator experience and device iterations. In low-risk patients included in the Partner 3 trial, pacemaker rates were not significantly different between TAVI and surgery, as shown on this one. Centers are achieving low single-digit pacemaker rates with improved techniques and post-procedural care, signaling that permanent pacemaker implant rates will continue to decrease. Here, the experience from New York Langone PPI experience with the METAS technique achieving a PPI rate of 3% with self-expanding valves. Then higher mild PVL rates, but not moderate or severe. Paravalvular leak rates were higher with TAVI than surgery in old generation TAVI devices. Moderate and severe PVL has nearly disappeared with contemporary valves. The effects of mild PVL are still unknown and may prove to be important, however, in patient health as we move forward. Durability, so far, so good. Valve durability shows promise with TAVI. Structural valve deterioration and bioprostatic valve deterioration are rare in longer-term follow-up. On the right side, on the left side, you see the studies. On the right side, the percentage of severe SVD, structural valve deterioration, and BVF, bioprosthetic valve failure. Comparing TAVI valve durability to surgery, however, is complicated due to small patient numbers in surgical studies, and of course, variation in definitions and surveillance, as shown here. Long-term data on TAVI patients is limited, since valves were implanted initially in older, higher-risk patients. Current data suggests TAVI has less structural valve deterioration than surgery in high-risk patients at midterm follow-up, as shown here. If you look at moderate SVD, higher in surgery than in TAVI patients. And finally, aortic regurgitation and bicuspid aortic stenosis. I think Susheel will talk about that. We know the challenges in pure aortic regurgitation and bicuspid aortic valve challenges. The low-risk Evolute trial demonstrated, however, promising results in low-risk patients with bicuspid aortic stenosis, including low rates of death or disabling stroke and no moderate or severe aortic regurgitation or annular rupture. Registry data confirmed these outcomes in bicuspid aortic stenosis patients, particularly with second and third generation devices. And finally, accessory devices make the TAVR procedure safer. Devices that will make those safer are summarized here, and they're currently under development. Future TAVR procedures may include a number of these devices. So what remains to be done? On the right side, what do these low-risk trials tell us? TAVI is safe and effective in low-risk patients, better quality of life with TAVI, similar PVL with TAVI and surgery. Evolute low risk, TAVI hemodynamic superior, in partner the same. TAVI superior to disabling stroke rates, sapien and partner the same. More PPI with TAVI, more left bundle branch block with TAVI. That's the discussion point that we just mentioned. So what needs to be done? We have to look into asymptomatic aortic stenosis, durability issues, TAVR proper valve selection, perhaps looking at PPM and hemodynamics, the question of cerebral protection in all patients, PCI post-TAVR with coronary access, and of course, anticoagulation therapy due to reduced leaflet motion and thrombosis. Finally, then, the future of TAVI. After a decade of rigorous clinical trials, we should no longer rely largely on surgical risk stratification to determine TAVR versus surgery case selection. I like this picture that I think was first shown by Dr. Leon. In the past, surgical risk would drive the choice between TAVR and surgery. Left side on the lower part. With TAVR now approved across the risk spectrum, TAVR will be the preferred therapy with surgery reserved for those who are not ideal for TAVR candidates on the right. The future, there are still gaps in TAVI knowledge which must be addressed, as mentioned before. And by all meaningful criteria, however, TAVI has been a breakthrough technology in the management of patients with aortic stenosis. And finally, dear friends, we all one world, one mission of making life better, safer, and healthier to all. Thank you very much, and be safe.
Thank you, Dr. Grube, for such an excellent presentation. It was, as usual, fantastic to listen to you. I'm now happy to say that Ganesh is here with us, and it'll be nice if we now have Ganesh to come and give us 2 minutes, and then Susheel, and then Vinny regarding the same topic, and then we'll open the floor to audience questions. Vijay, if you can make a note of the audience questions that I can see flying in front of me, you can pull them up and then ask them to our panelists.
I guess I'm going to start my comments by 2 things. First, to tell you what we do now, unit. We still have the MDT for every potential TAVI patients. At present, patients who are 85 and older, they are still discussed, but they automatically offer TAVI. Anybody from 80 to 85 in our unit, we have discussed there is some pushback from the surgeons, but invariably they go ahead and get TAVI. The patients who are under the age of 80 in our unit, we do have, at least from 75 to 80, the discussions get a little bit more animated, shall we say. And invariably, those age groups, the surgeons would insist on seeing the patients first. And invariably, the patients then will tell the surgeons, well, you know, the data is there, perhaps I will go for the less invasive method. Under 75 in our unit at the moment tend to go for surgery unless there's absolute serious mitigating surgical risk. What we have noticed, how in the last 6 weeks, at least last 6 to 8 weeks with COVID-19, all patients currently on the surgical waiting list above the age of 75 or even above the age of 70 were rediscussed. And the vast majority of them, if they had no other complex, you know, there are no other coronary artery disease or complex coronary artery disease or other valve disease, have all been pushed to TAVI, and they've all had their TAVI in a much quicker time. So it's quite interesting how the data is there. Eberhard has shown it very nicely in the low-risk patients, moderate-risk patients, and high-risk patients. But transferring the data to how units practice, I think, has changed or is slowly changing. But I think what we really need is for the guidelines to support the data. And I think that will come with time. I'll stop there.
Perfect. That's a clean, neat, crisp summary. Susheel, you want to weigh in?
Yeah, I mean, I think that was fascinating. It was a great talk. I mean, you really sort of summarized the issues very effectively. And I think, you know, we look at it a little bit differently, and, you know, Vinny and I are working together so he can give his comments, but I think it's making sure we do the right thing for the patient and making sure the patient is informed in the end. And, you know, the issues are, I think, the less invasive, lower risk procedure. I think it's a great procedure. It's a predictable procedure in the right anatomy. And I think that's one of the key things. You know, I think centers that have done a lot, that people have been involved in it for a long time, I think we all, you know what's good anatomy. So for me, a 70-year-old with ideal transfemoral anatomy that's getting a large transcatheter valve is very different than a 70-year-old with borderline access who weighs, you know, 100 kilos and is getting a 23-millimeter valve. Those are very different scenarios because that means different things to that patient in terms of the ultimate result. So I think we have to be confident in our ability to screen and decide what is the likelihood of getting a great result, an average result, and a poor result in that patient. And Eberhard's point of, it's not about risk of surgical risk we should get away from. We should look at what is the TAVI risk, what is the surgical risk, what is the coronary disease situation. If they have multivessel disease with a syntax score, you know, of 30, that's a different patient population. That patient maybe will be better off with CABG AVR if they're not high risk for surgery. That same patient, if they're high risk for surgery, yes, you can do it less than ideal. You could do PCI and TAVI. And so I think those are sort of important considerations to look at. And someone raised the issue of the younger patient and what do you do with younger patients? So the 55-year-old, 60-year-old, and I think that aspect of it is a challenging one, and maybe I'll leave that to Vinny to discuss. You know, bicuspid is different. We need a lot more data about bicuspid and to understand the results. But even tricuspid 60-year-old, we're likely not going to get them through their life without surgery if we look at average survival of 85. And you know, if you do TAVI, the argument of doing TAVI now and then surgery as their next therapy, and then TAVI if that fails, is what we discuss with patients. What we don't have data on is how hard is it to re-up. Are we putting patients in a bad position by saying, yeah, do TAVI now when you're younger and then get surgery later? Because we don't know right now, realistically, how hard and how complex are we making that surgery by doing TAVI now. But I can let Vinny maybe comment on that issue a little bit more.
Hey, Vinny?
If I may, yeah.
Yep.
Go ahead.
If you can hear me. So this is a very interesting time for surgeons, I think, because as Eberhard pointed and all of you have pointed, you know, TAVI has become definitely the first line therapy. We always, or at least our philosophy has been to match life expectancy of the patient to the valve. So in old days, we used to think, okay, you know, the TAVR devices are always going to outlast the patient. So we were not that worried. But now a time has come where you need to balance between the life expectancy of the patient and the durability of the valve as well, whichever valve that is, whether it's surgical valve or it's a TAVR valve. So I think this is the time when you're definitely going to get a lot of opposition from surgeons and as Ganesh said, that, you know, it's geographically different in every center. One of the really good indications, even in younger patients in my mind, for example, has always been patients who have had, say, coronary artery bypass grafting before. Because we know that the life expectancy of these patients is never more than 10 or 12 years, if they are age 70, for example. And these are the patients surgeons probably don't want to reoperate as well if we have good anatomy and you can do TAVR. So this was one of the first indication creep, at least in London when I was there. And I think in Colombia, in fact, if it's a re-op, we always look at, can we actually do a TAVR and give patient a really good result? So it's a complexity of things. One of the things which I have observed, and it's not being a critique of cardiologists, because as you know, I interact with cardiologists very, very well, and I'm very forward thinking, is my fear at present is that we are extrapolating a lot of data from one device to all the 6-7 devices in the market. And I think we should be a bit cautious about that, because we cannot, for example, take partner 3 data, which is with one particular device, and apply it to an emerging device. And that's the mistake surgeons have done in the past as well. Like a good durability data from one particular valve was, you know, blanketly applied to all of them. And then we realized that all valves don't last, you know, 10 years or 15 years, but some of them only last for 2 or 5 years. So that's one of my major concerns, that when we apply the data, we need to definitely apply the data slowly, which is device specific as well, when we consider each patient. The second thing is, you know, TAVR is not magic. Means it has its own limitations, and we need to understand the limitations as the time goes, and then recalibrate the therapy area in a patient's lifetime journey. And as Susheel has mentioned, you know, we are making a lot of effort now from at least our side to document how difficult it is, for example, to explant the TAVR. There's a misconception that every time a TAVR is explanted, you have to do a root replacement. And what we have observed is that's not very true. And I think in recent future, I suspect we will be considering TAVR in even 65-year-olds if we can document that at age of 72, 75, we can actually do a first-time open heart surgery without increasing the risk of the patient, and then implant, you know, a surgical valve with a very low risk to give patient only one open heart surgery, or even if needed, even TAVR in TAVR. So I think time's going to tell us how we use this smartly. Thank you.
So can I ask a few questions or a few remarks? I think what listening to Susheel, he's always a wise man, and he always says things right. And I think there's no question about it at this point, at least in my view, that we have to be very careful, given the reasons that the three of you mentioned. Be very careful on a forward-going basis if we talk about any data, you know, in a 60 or 65-year-old. Not only the durability questions, but also, you know, the surgical questions. I'm just thinking while I was listening to Vinny, the surgical explant in a patient with, as an example, a larger valve like a core valve or portico, maybe a little bit more difficult than a smaller valve like the Sapien. So is there a difference in surgical time risk between different devices? The second thing is what Vinny mentioned is kind of interesting to me, because when we started this journey, the good news really was that initially all the important endpoints, maybe let's take the pacemaker rate a little bit aside for us for now, were basically the same. And that applies to the self-expanding valves as compared to the balloon expandable valves, with a difference initially when the journey was started, when the companies were hitting each other, saying, you know, this is better, that is better. And at the end of the day, the good news was that fundamentally, the data were the same. Now, I'm not so sure whether that's true for all the devices that are coming into the field, but the ones that are in the market now, I think they have proven to be safe, to be effective, to have more or less the same endpoint data, if I may say. The new ones coming in, we have to see. But I think the good news is here that the physicians are relying on long-term data. They don't jump on these valves simply because they are less expensive, but on the data that have been and the patient data that have been studied rigorously and vigorously during the last 15 years. And I think that's a very, very good news. As far as the age is concerned, I think we have to be careful whether we say, you know, a 65 can be better served by TAVI or better served by surgery. I think that's why we have, at least in the units that are functioning well, that's why we have a heart team that is not competing against or with each other, but looking at the patients first and decide together what's the best way to move forward. And I agree totally with all of you. Also what Ganesh is saying, that there is a growing discussion right now, animated discussion now as we move potentially into younger age. But I think it is important that we state, or the four of us anyway, at least from my point of view, that low risk has nothing to do primarily with younger age. That is a different story with different risk evaluations and different risk strategies. Thank you very much.
I mean, nobody could ask for a better sum up, and it's always nice to look at the elephant in the room from everybody's perspective. We are at about 5 minutes, 34 seconds. I think we can take one question because there's already so many people in the audience. We're at 390. Vijay, do you have any question that you think you want to put?
Yeah, there's one question that related to pacemaker implantation patients with TAVI. That is from Dr. Rajan. How can one reduce the pacemaker implantation with TAVI? Any tips and tricks? And another related question from Dr. Parminder. Do you think planning the procedure by measuring the membranous septum length routinely has the potential to reduce pacemaker implantation? These are the two questions. All others have been answered already.
Perfect. So Ganesh, why don't you take these questions quickly, and then we'll move on to Susheel's talk.
Multiple causes, I think, for pacemakers. And I think all of us, I think, would agree that if you deploy the valve as high as you can safely, we will see a reduced risk for pacemaker implantation. And so I think that's what we should all routine, not 0 or -1, but 1 to 2 to 3. If you do that routinely, you have, I think, you will see a lower risk. But if you have pre-existing conduction disturbances, right underbranch block, very prolonged left underbranch block, I think you're at a higher risk of pacemakers. The membranous septum length is a new evolving thought process. I think some people use it, some people don't use it. I personally don't use it for two reasons. One, you have to have super excellent quality CT to be able to measure accurately. All the softwares that currently we use for measuring will have an error of 1 to 2 millimeters built into the software. And when you read the data on it, it's a very fine margin between 4 to 6 millimeter membranous septum length depth for you to deploy it. So even if you measure it correctly, you need to then measure and deploy it correctly on a fluoroscopy, which is a moving target. So it's a very, very difficult, I think it's a very difficult way to be absolutely sure that you are 8, 6, or 7. So my thought has always been, yes, it gives you guidance on to predict pacemaker or no pacemaker. But I think when you're deploying the procedure, do it safely, don't be aggressive, deploy it as high as you can, but not at 0 or 1, but at 2 to 3.
I just want to add one quick comment to that, because I think there has been a lot of interest in reducing pacemaker. I think that's an important consideration. But in the end, especially for operators that are relatively new to the field, you don't want to try and deploy high and end up with a pop out, right? And so a lot of this stuff comes with experience. And the key thing is to do the procedure safely. So if early on you're trying to get to 0 and you pop out, that's a problem.